So the clock has turned. Welcome all to Medical Oxygen and NCDs. This is the fourth in a series of high-stakes conversations on medical oxygen, hosted by the Every Breath Counts Coalition. I'm Leith Greenslade, coordinator of the coalition, and delighted to moderate the conversation today. So in just 1 week, government leaders will attend the UN high-level meeting on NCDs and mental health here in New York City at the UN General Assembly. Despite the fact that medical oxygen is an essential medicine for the management of several NCDs, it isn't mentioned once in the draft political declaration that governments are negotiating. And we need to change that, especially as it relates to chronic respiratory diseases, principally COPD and asthma, and congenital conditions. Why? Because more than 650 million newborns, children, and adults live with these conditions where oxygen is often needed. And as the Lancet Global Health Oxygen Commission reported earlier this year, most are not getting it. So today we brought together a group of speakers who represent many different perspectives on the issue of medical oxygen and NCDs, including medical and academic experts, survivors, family members, and advocates to share their views. Our ask to you is that you listen to their arguments and add your voice to the call to include medical oxygen in the NCD Access to Medicines agenda. Please post questions, comments, and relevant links in the chat throughout, and we will attempt to answer them live. We are recording and will post on YouTube later today. So my pleasure now to introduce our first speaker, Dr. Nalima Navaluri. She's Assistant Professor of Medicine and Assistant Research Professor of Global Health at Duke University here in the United States, and she'll be talking to us about chronic hypoxemia and medical oxygen. Nalima.
Good morning, good afternoon, and thank you, Leith, and for that wonderful introduction, and thank you all for being here and joining with us today to talk about something that I'm incredibly passionate about, which is the urgent and growing need for long-term oxygen therapy for chronic lung disease. So there are 3 major points that I hope you leave this webinar with today. The first is that the burden of chronic hypoxemia from non-communicable diseases is not well measured globally, but our data shows that this is much more common than we may think, and it is likely growing. 2, we have to think about oxygen as an essential medicine, not just for acute processes such as pneumonia or COVID-19 or around surgical needs, which are also extremely important, but also for chronic or non-communicable diseases, which require systems to provide long-term oxygen therapy that are distinct. And 3, we're essentially failing. The current infrastructure for long-term oxygen therapy in much of the world is significantly lacking, and there is an urgent need to address this need for long-term oxygen therapy to help our patients. So in 2019, chronic respiratory disease affected nearly 500 million people and was the third leading cause of death worldwide, responsible for about 4 million deaths. The most common chronic respiratory disease is asthma. The most deadly is COPD or chronic obstructive pulmonary disease. And this burden is not borne equally. So low and middle income countries have the highest rates of death and disability from chronic respiratory disease, while high income countries have the highest number of people diagnosed with chronic respiratory illnesses, in part due to better diagnostics. And the biggest known drivers of disease include tobacco smoking, followed by air pollution and workplace exposures. So why is oxygen therapy so important for chronic lung disease? Well, chronic hypoxemia or low oxygen levels that persist for months is a sign of severe chronic lung disease and is a major contributor to early death and reduced quality of life and functional status among individuals with lung disease. Providing oxygen therapy was found to save lives in 2 landmark studies that were conducted over 40 years ago by the British Medical Research Council, or MRC, and the National Heart and Lung Blood Institute in the US. And these studies found that for patients with COPD specifically and chronic severe resting hypoxemia, which was defined as an oxygen saturation of less than 88% on room air without oxygen for at least 3 weeks, despite optimal treatment and stable conditions, that using oxygen for at least 15 hours a day or overnight while sleeping improved survival by as much as 50% at 3-year follow-up. It is also now known to improve sleep, cognitive function, emotional status, and slows the progression of other diseases like hypoxic pulmonary hypertension, not only in patients with COPD, but in patients with chronic hypoxemia from other diseases as well. And this data established oxygen as a life-saving therapy that in many high-income countries is covered by insurance if certain criteria are met. So in the US in 2021, over 1 million Medicare patients received oxygen therapy at an estimated cost of 800 million US dollars. But there's still a lot we don't fully understand about the burden of chronic hypoxemia in low and middle income countries, including other major risk factors and the experiences of patients with hypoxemia and their ability to access oxygen and diagnostics and care in these settings. So this picture here is of a woman I took care of on the wards in Uganda who was sitting on her bed, appeared very comfortable, but complained of shortness of breath when she was walking. I was shocked when I put a pulse oximeter on her and found that her oxygen saturation, that number in the left that says percent SpO2, was in the 50s, a number that would sound multiple alarms and have people rushing into her room in hospitals in the US or Europe. But here she was chatting with me, really not appearing any like visibly short of breath. And this was one of many experiences which set in motion a series of studies I've led to better understand chronic hypoxemia among adults in East Africa. So I'll talk with you about those for just a little bit. One of the first studies we did was to try to determine the number of individuals coming into a major national referral hospital in Kenya who were hypoxemic. And of those, how many were chronically hypoxemic? So this is a really busy figure, but try to just focus on the 2 red circles with me for just a second. So to do so, we had a rigorous screening procedure where we checked pulse oximetry on every patient who was admitted to the medicine wards. This was a departure from standard practice, as most patients at this hospital do not have oxygen saturations checked on admission routinely, and oxygen is often prescribed based on perceived shortness of breath by staff rather than formal assessment. Once we found a patient who had low oxygen saturation, which we defined as 88% or lower, we followed them to see what happened throughout their hospital stay. We wanted to know if their hypoxemia resolved while inpatient, how many died, how many were transferred to higher levels of care, and we also followed patients who did not resolve at 1 month post-discharge to recheck their oxygen levels. We ultimately found that nearly 1/4 of patients admitted to the hospital are hypoxemic on admission, and that in total, about 2% of patients admitted are chronically hypoxemic, or about 1 in every 12 patients who are hypoxemic on admission. These are massive numbers, especially when you compare to high-income settings where the numbers are closer to 2 to 5% of individuals admitted to the hospital being hypoxemic. So what happens to those patients who are hypoxemic when they're admitted? Well, almost about 1/3 of patients die, and then another third resolve. But despite this high mortality rate, only 11% of patients are transferred to any sort of critical care unit, where traditionally patients with really severe hypoxemia go to for advanced therapies, higher levels of oxygen therapy, or ventilation. And so, what do we know about individuals with chronic hypoxemia who are admitted to the hospital? Well, there seems to be a slightly higher proportion of women with chronic hypoxemia, and women on average are older than men. We also found that about 1/3 of patients with chronic hypoxemia died during our follow-up period, and about half of those died during their inpatient admission, with the other half dying in the weeks following their discharge. We also asked participants whether or not anyone on their team discussed oxygen with them and found that only 38% had any sort of discussion about home oxygen at discharge, with only 10% of participants actually able to have oxygen at home at discharge. For reference, the cost of oxygen in Kenya in 2019, when we first started this study, averaged about $50 per week. And we know from our prior work that the average daily wage in this population at the time was about $2 per day, making the concern about cost a really significant barrier. The next phase of the study was to try to understand risk factors for chronic hypoxemia in this population. And to do so, we compared individuals with chronic hypoxemia and controls who were admitted to the hospital during the same time but were not hypoxemic. What we found was that individuals with chronic hypoxemia were older, were more predominantly female, had higher rates of tobacco use, and prior tuberculosis infection compared to controls. They also had similar rates of HIV and biomass fuel use. But prior TB was the most significant of these factors. And so while things like age and tobacco use are maybe not that surprising based on other data, our findings about females and prior TB were really striking, especially at the time. And we now better appreciate the impact that tuberculosis has on the development of chronic lung disease in many high TB burden settings, with studies showing that over 50% of patients treated for tuberculosis go on to have some pulmonary impairment in the years following TB treatment, and that TB survivors have 3-fold higher risk of death compared to the general population in the 10 years following treatment. And this study really just speaks to how sort of global burden estimates don't necessarily capture some of these unique risk factors in low and middle income countries or high TB burden settings that might be driving chronic respiratory disease, chronic hypoxemia, and oxygen need. But what does all this mean to patients and to health systems? Well, individuals with chronic hypoxemia have longer lengths of stay in the hospital, which means greater cost to themselves and to their system. And while they have similar mortality rates at discharge from the hospital, individuals with chronic hypoxemia are more likely to die in the 1 month following hospitalization than their non-hypoxemic counterparts. Much of this is driven by individuals who are not prescribed or who cannot afford access to long-term oxygen therapy for home use. And to reinforce some of the findings from our first study, of these 108 individuals with chronic hypoxemia, only about 60% were actually placed on oxygen at the time of admission, suggesting their hypoxemia was not recognized, likely because they looked as comfortable as the woman I took care of in Uganda did with an oxygen saturation in the 50s. Less than 10% had home oxygen when they were admitted at home with them, and less than half had oxygen discussed with them during their hospital admission, suggesting that providers are either not aware of the benefits of home oxygen, which is less likely, or are reticent to prescribe something and discuss something they feel their patients cannot afford. And as we think about the types of delivery devices that exist for home oxygen that may be most cost effective, one of the things that comes up most often is oxygen concentrators, which traditionally require electricity to run. But fewer than half of our patients had electricity in their homes. And among those who did, most had power outages at least 1 to 2 times per week for at least 1 to 4 hours each time, with only 3 patients owning any sort of generator to provide backup power. So it really speaks to the barriers that exist in trying to think about how we develop systems to prescribe and access home oxygen. Patients also shared with us in their own words the impact oxygen has when they came for their post-hospital follow-up. A male who was not using long-term oxygen therapy at home stated, when you want to breathe, there's something that was blocking air and made it flow slowly. But when I was put on oxygen, that thing goes away. It's like a door closes, but when you open it, air flows inside. Another male patient who did not have who did have long-term oxygen therapy via concentrator talked about the benefit of oxygen keeping them out of the hospital and seeing themselves as not sick. Another male who didn't have long-term oxygen therapy talked about how they didn't get any instructions from their doctor about oxygen and felt in the dark. And finally, a female patient who was prescribed oxygen but could not afford it described how she was given inhalers instead of oxygen, while her family and she struggled to find the money to pay for oxygen therapy at home. So while my work has been focused in Kenya, this issue is not specific to East Africa or even sub-Saharan Africa. The global need for oxygen is incredibly high, with an estimated 374 million people who have oxygen needs each year. And as a member of the advisory board for the Lancet Commission, we found that there wasn't enough data to accurately quantify the number of people who might need LTOT or long-term oxygen therapy from all causes, but at least based on data for COPD, I think it's at least 9 million people each year and likely growing. So just in case these points aren't clear, I just want to reiterate, chronic hypoxemia from non-communicable diseases is a major growing issue, especially that disproportionately affects LMICs. And long-term oxygen therapy is a life-saving, life-prolonging essential medicine, and we must work together to build the needed infrastructure to make sure long-term oxygen therapy can be equitably accessed across the world. Thank you.
Brilliant. Thank you so much, Nilima. And if you can post in the chat some of the links to some of your publications, this data is critically important and all too rare. So we depend a lot on the work you and your team have produced moving forward. So thank you. Let's turn now to someone we're very delighted to have, Professor Jeremiah Chakayamua, Professor of Global Respiratory Health at the Liverpool School of Tropical Medicine. I think he's based in Kenya at the moment, but he's truly global. And he'll be talking about post-infection chronic respiratory disease and medical oxygen. Welcome, Professor.
Thank you very much. I hope I can be heard.
Yes.
It's really a great pleasure to have been invited to speak at this webinar. I think the topic that we are talking about is extremely important, and especially for people like us who live in settings where access to healthcare can be a big problem. I was requested to talk about post-infection chronic respiratory disease, and maybe a good place to start is the numbers. And I think Nelima has touched on this a little bit. But certainly chronic respiratory disease due to a previous respiratory infection are a major public health problems in the world today. Maybe the most studied, the most well-known is post-TB lung disease, which is estimated to, at least by 2020, probably contributed more than $58 million, or 47% of the total TB burden by that time. There were more than 155 million survivors, TB survivors, by 2020, and nearly half of those individuals will have some form of post-TB lung disease. So it's a real big problem, but it's not the only problem that we have to deal with in relation to the need for continued care, including oxygen treatment in people with post-infection lung disease. So we have people who have suffered pneumonias in the past. We have a lot of people who have bronchiectasis. Unfortunately, the burden of bronchiectasis in places like in my country is not known, but it's a huge problem. More recently, of course, we had COVID-19 and post-COVID lung disease came to the fore. But these things have been with us for a very long time, and we all need to be very familiar with these things. If we are going to address chronic respiratory disease and the need for oxygen in individuals with chronic respiratory disease because of a past infection, it all begins with the diagnosis of that condition. And unfortunately, the tools that are available for diagnosing post-infectious lung disease are largely available in many parts of the world. In low and middle income countries, including my country, Kenya, these things are not easily available. So spirometry, lung imaging, even simple things like pulse oximetry, like Nelima said or showed us with that picture from the Ugandan lady, these things are not routinely available in our setting, which basically therefore means that a lot of people who need to be on oxygen are not diagnosed, and therefore they are not provided with the treatment that they need to be able to survive their disease. These are the basic management principles for people with post-infection lung disease. If it is possible, you want to prevent progression of that disease and to manage symptoms. And the key symptoms in most of these individuals will be cough, with or without production of sputum, shortness of breath, and impaired physical fitness, and functionality, and so on and so forth. That treatment, the treatment that is currently recommended for these individuals would include all sorts of things, including bronchodilators, inhaled corticosteroids when those are indicated, and often antibiotics for acute exacerbations, especially for individuals with bronchiectasis. But as we all know, access to inhaled corticosteroids and bronchodilators in our part of the world can be a big challenge indeed. Oxygen treatment or oxygen therapy for those with chronic hypoxemia, like you've already been told, is a big issue. But it's important for us to know that oxygen therapy should not just be the only thing that you provide to these individuals. You need a comprehensive management system where people are provided with pulmonary rehabilitation. And for those with chronic airway mucus retention and infection, airway clearance techniques are critical. But oxygen should be part and parcel of the treatment or the care that is given to these individuals. So what are the issues in terms of availability of medicinal oxygen and access to this essential treatment? Unfortunately, in many parts of the world, including my own part of the world, oxygen, medicinal oxygen, is largely unavailable. And there have been many surveys that have been done by various groups of individuals that show that availability of medicinal oxygen is less than 50% in the places where it should be. And those shortages tend to worsen during surges like happened during the COVID-19 pandemic. That was a real big crisis, even though, for example, Africa and other parts of low and middle income settings had a relatively lower burden of COVID-19, but the systems were so weak that those who were affected by serious forms of COVID-19 had worse outcomes, as it were. And the unavailability of oxygen tend to disproportionately affect certain populations, such as the poor and those who live in rural areas. There are many challenges to the supply and availability of oxygen, including the fact that in our parts of the world, there's limited oxygen production capacity. There is over-reliance on cylinder oxygen, which apparently is costly and needs to be transported around. So the logistics for moving oxygen around is a big issue. And for concentrators and stuff like that, if you have a problem with electricity, then you cannot use your concentrators. And these are problems that tend to affect both people in the healthcare settings and people who have chronic respiratory disease in their homes. Financing is a big issue because oxygen at this moment in time does not seem to be budgeted for as part of the essential package of care that should be delivered under the universal healthcare packages. So a lot of people who need long-term oxygen have to pay for it out of pocket using cylinders, for example. And there is no data, and this makes it very, very difficult. If you don't have data, you are not able to plan for your oxygen supply system. You do not know how many people need oxygen, how much oxygen is being used, by who and where, and that really, really affects planning and investment. So how can these problems be overcome? I think we need to work really, really hard to make policymakers, governments, and everyone recognize that oxygen is an essential medicine and must be included in the UHC benefit package and therefore budgeted for and procured by the systems that we look up to supply medicinal products to people who are unwell. We need to diversify supplier of oxygen and not just depend on cylinder oxygen. We must ensure that people are linked to reliable power where that is to ensure, for example, that people who are on oxygen have access to their oxygen all the time. But I think it's really, really important to roll out pulse oximetry everywhere. And this did happen during the COVID-19 pandemic, for example. We must also train our clinicians to be able to understand, to know when to screen people for hypoxemia and when to know the cutoff points when they should start thinking about providing oxygen. But there's one thing that is really, really important. Running around with oxygen therapy, for example, even for the individuals that I have seen in my country who can afford, for example, portable oxygen concentrators, it's an extremely stigmatizing situation. So we must work on the stigma that is also contributing to poor access to medicinal oxygen. Thank you very much for listening to me.
Brilliant. Thank you so much, Professor Chikaya, and also for covering all the solutions, the things we actually need to do. So thanks so much. Let's pivot now from chronic respiratory conditions to another NCD that is all too often neglected. It's congenital conditions. And we have today someone really special, Anna-Marie Saarinen. She's CEO and research officer with a company called Bloom Standard. She's also board chair of an NGO she co-founded called the Newborn Foundation. She's an entrepreneur and she's a parent of a wonderful daughter living with a congenital condition. So Anna-Marie brings her whole self to this challenge. Over to you, Anna-Marie.
Thank you so much, Leith. It's a pleasure and an honor to be here among your esteemed guests. If you're seeing all right.
Perfect.
Look good?
Yeah.
All right. Thanks so much. And thanks for letting me shine a light a little bit on how NCDs and medical oxygen access are so impactful for this patient population that so often is overlooked, underserved, and not really by choice, but because of all the issues that we've heard from the other speakers around access to care. And of course, medical oxygen is very much part of that pathway, and how children survive long enough to get the care that they need in places around the world. So as Leith mentioned, my daughter was diagnosed with congenital heart disease as a newborn. She was otherwise asymptomatic and was to be discharged home from the hospital in heart failure. And so I think what's interesting about her story is that she was indeed cyanotic, but she didn't look like she was sick. She looked perfectly healthy, so there were no other real indicators for us to know that we had a baby with a ticking time bomb, inside of her chest. And so I think as we finally, got a diagnosis and started on our care journey, I realized really how profound the burden of disease related to congenital heart defects was. That really 1% to 2% of children around the world were diagnosed with congenital heart defects, and that it really took out a huge percent of non-communicable diseases and the highest number of deaths, morbidity associated with birth defects globally. So there are indeed a great many children living around the world with CHD because they're either able to get a modicum of treatment along the way or are able to have a surgical intervention. But we still have major gaps in care, major gaps in diagnostics, and of course, treatment infrastructure. And as we are talking about today, oxygen is absolutely essential for the care of children with congenital and pediatric heart diseases. The 1 in 3 have access is a statistic from the WHO around access to oxygen for pediatric patients and children under 5. It's actually much lower than that if you connect it to newborns in global health settings. So every 5 minutes, there are 10 more children born with congenital conditions that affect the structure function of their heart. And I think as we tie this into the larger understanding of what our population looks like with children under 5 and the percentage of children with disabilities that are represented by non-communicable diseases, these numbers start really being impactful in global health. So with congenital heart disease, we're not really seeing the decreases that we see in other conditions around the world that have had some sort of direct intervention, either for the mother during pregnancy or for children. So we're either holding steady and in some cases actually increasing, and certainly we're increasing in the scheme of the other things that cause morbidity and mortality among newborns, infants, and young children, because we're making progress in the other areas. And again, a lot of this has to do with treatment infrastructure, but medical oxygen is very much part of the treatment infrastructure and the treatment pathway for these children. I threw this one in there because I know Leith is a huge fan of this as well. Those of us who work on health economics and epidemiology and care about how these numbers are shifting use this as a resource often. So if you want to spend a little more time diving into how NCDs are impacting babies and children and which ones are impacting areas most profoundly, please do use this resource because it's incredibly valuable and it's very timely and kept up to date. So on my daughter's journey, pulse oximetry became a very big part of my life very quickly, because even in the United States, we weren't screening babies before they left the hospital for cardiac conditions. So one of the tools that was being explored in other countries was pulse oximetry. And we did a large study here in the United States out of my daughter's hospital and several around it, along with the State Department of Health, to look at whether pulse oximetry was an easy and feasible tool to identify otherwise asymptomatic children. And that led to some advocacy, parent advocacy, and medical society advocacy to include pulse oximetry onto the federal panel of things that we screen babies for in the United States. And of course, this is very much pre-COVID, but I like to think that there was a good foothold, at least among babies and children for understanding that pulse ox can be a really valuable adjunct tool, even in the most primary care settings for evaluating kids. So this photo is another project I did with Massimo and the Gates Foundation to develop a tool that could measure both oxygen saturation and respiratory rate in children. And in this case, we were really targeting pneumonia, but it turned out that we were picking up many things, including congenital disorders, when we were using a pulse oximeter to screen these children. So as you can imagine, if you're in a setting like this, which was a typical community health center clinic, where children are coming in, we can throw a pulse oximeter on them, find out, much like Nalima was saying, that they're hypoxemic. They've probably been hypoxemic for quite a while, and there needs to be some action taken pretty quickly to get these kids regulated. And in most cases, including this clinic that I was standing in here, medical oxygen just was not a thing. This would required at least a 20-kilometer travel to get to a place where the child that's hypoxemic would be able to get oxygen. So I provided just a little additional background here on congenital heart diseases and cyanosis and non-cyanotic heart diseases, just to help level set with our kids that they're looking for with that pulse oximetry screen before discharge to home are these conditions that will manifest right then and there with an abnormal oxygen saturation reading. And then you've got a decision tree of what to do next. And it really, any level of care provider can do this screening. It's really very simple. And the Newborn Foundation has spent over a decade training, implementing, and bringing equipment into these settings. But what's interesting is that there are non-cyanotic heart defects. They might not pop up on the pulse oximeter, but that doesn't mean that these children with congenital heart diseases that are very serious won't require oxygen. As the fact is, 96% of children with congenital heart diseases and pediatric heart diseases require medical oxygen. If not routinely, certainly during the acute stages of their care pathway. Without it, they will not survive. This is the algorithm that we use for screening, and this is why pulse oximetry and oxygen are such a beautiful combination of technologies. And you know, they're both amazing on their own, but they do better together for all the reasons you can imagine. So there have been a number of papers published around this, some of which I've co-authored, and many of which continue to look at the challenges around medical oxygen and knowing when to oxygenate, especially babies, so that we're doing it the right way when we do have access to oxygen, and just working on getting more tools into the hands of the places that are seeing these kids on the front lines. I lastly wanted to share, this is pretty recently published research looking at a correlation between pulse oximetry values and abnormal echocardiogram results. And what's interesting here is that 65% of the babies with a detectable abnormality on an echo screen also had an abnormal pulse oximetry reading. And while that might sound like, okay, good, that's a good proof point, you know, it's also showing that 35% did not. And so having the tools that are going to enable faster and more efficient access to critical oxygen for these kids is absolutely essential. And this is why I'm so really thrilled to be bouncing on the heels of this this resolution and the work leading into UN, because it's really, really critically important. And this was a little bit also part of the same study where we could show that more than 10% of patients that are having a screening, just a screening, had a change in care pathway based on their SpO2 result and then ultrasound screening. And as you can see, these were tied to a number of cardiac and cardiopulmonary conditions. Actually, very few of the conditions were not NCDs. But of these, 96% required medical oxygen for their care pathways. So these are just some final photos that I've shared from the field. All of these are with consent from the facility and the patients. But you know, on the left, you can see a place where we've got babies and mothers. There is no oxygen at this facility at all. The patients, any patients would need to be moved to a different facility, and this is one of the largest delivery centers in this particular region of the Philippines. And then these other two photos, one taken outside of the facility. All of these tanks are empty. And also the ones in the elevated care nursery at that hospital, in that case, were also empty. So as you can see, I think I wear a couple different hats here. Of course, one focusing on early detection and being able to monitor and risk stratify patients that have a known condition. But the output is significant, either way, right? We're looking at these conditions being responsible for, nearly a third of newborn infant mortality, and medical oxygen is just playing such a critical role in trying to reverse this trend. This is finally a newer picture of my daughter, who's turned out to be quite the artist, and I'm incredibly proud of her. And I think all this work for me leads to an opportunity to provide other patients, other families, other providers that care for children, the same opportunity that my daughter has had. So thank you, Leith, for letting me share a bit of our journey.
Beautiful. Thank you, Anna Marie. And tell Eve we agree she's a great artist. That's a beautiful picture. Thank you for sharing. All right. So our next speaker is a survivor. It's Alexander Mandel. He's a long-term oxygen therapy user, although there's a happy end to this story. It's a very compelling survivor story, and Alex has published it today. So we're publishing that for him. I'm just going to put that in the link for you in a moment. But Alex, I don't want to steal any of your thunder. Over to you.
Yes, hello everyone. So thank you, Lei, for introducing me and for letting me participate. So as Lei was just saying, I'm indeed a survivor. So I'll quickly go over my story and try to explain a little bit how it feels, and I would say the journey from a patient point of view of being, with COPD and with basically oxygen deficiency. So my journey starts on September 11th in 2001 at the World Trade Center. I was working nearby. It's at the time it was Wall Street. It was quite a privilege to have achieved, I would say, working in such an area. And then basically the events of 9/11 happened. The towers collapsed, and I ended up breathing all the toxic dust from the remnant of the World Trade Center, and immediately, I would say, after started coughing. And then, the cough stayed with me for several years. So the 10 years following, I was not diagnosed. I had my career, so I was an investment banker. I was working at Goldman Sachs, which is quite, I would say, an Olympic goal if you work intellectually and if you want to work in finance, it's pretty much being part of an Olympic team. So after 1 year, I realized I didn't have what it takes anymore to be part of that Olympic team. And I would say that was the first thing I noticed, but I thought it was just me, that I didn't have anymore the drive. So I left banking, basically, started relocating, started thinking a little bit more about, life, I would say life-work balance, a little bit more towards life, being more relaxed. And so my wife and I decided to move to Barcelona. And started to live more a Mediterranean lifestyle, much more relaxed, and started our own company, but basically without understanding that I didn't have anymore what it took, simply for lack of energy. So there's a lesson that I just discovered after, is that when you lack oxygen, your brain is tricking you, and you believe that you're fine, and you find like all sorts of excuses not to blame. You're basically trying to find light excuses to avoid thinking that you're sick, and that's exactly what I heard from the previous speakers, that people which have oxygen deficiency quite often define themselves as perfectly healthy. And that's what I was doing for the following 10 years. until I reached a certain type of markers which felt abnormal. Like there was a certain point where, I couldn't lift my own children anymore. So, I mean, I had a normal life. I had my company. I was traveling a lot. I had, 3 children, but the third one, I became too weak. I couldn't lift her. And first I was like, okay, she's too heavy. But then I was like, wait a minute, the others are heavier and I could lift them. So at a certain point, I had to admit there was something wrong. I did a checkup in 2011, and even then, and then, it goes also to the doctors. I think there's also a lack of, I'd say, of recognition that you can be perfectly healthy but have a chronic lung deficiency. And the first thing I remember is that they were literally hitting, I would say, the oximeter, thinking that the oximeter were broken, took another one and a third one, because when they put me on a bike to pedal, I was, dropping at 65 or 70%. So it took quite a while until I was sent to an neurologist, and I did a spirometry, and then it became obvious that my lungs were heavily damaged, and my lung capacity was like back then at 46%. But even then, I was not offered oxygen. It was like, okay, just abstain from doing heavy effort, and you'll be fine. Which is what I did. So I followed my path. I continued with my career. At some point, I didn't have enough willpower anymore to lead my own company. So I went back to corporate. I was in e-commerce, so I found a job at Amazon. I discovered that I needed to be pushed because I couldn't push myself anymore. But being pushed, having like a boss who would tell me, what needs to be delivered, etc., I managed to go on. My performance at some point was not very good. I was, in danger of losing the job. Then I started realizing, okay, I need to consult. I'm constantly tired, but always finding excuses. And today, when I try to explain this to others, it's a little bit like if you have a phone battery that progressively is degrading, and your phone battery at the beginning charges to 100%, but at the end is charging to 2%, even if you charge it all night. And that's how somebody with lung deficiency is. The only difference is we don't have a percentage indicator, so we don't know. And our brain is tricking us and making us think, yeah, I feel a little bit weak, but and there's always some but. So this I would say is one of the things that have been identified here is pulse oximetry, and now we have more and more portable devices. This should be like so standard, such a natural, I would say, reaction to, oh, I feel a little bit tired, rather than I need to sleep, etc. Let's measure, the pulse. Let's measure the oxygen. Not even the doctors, not even in countries where there is plenty of healthcare available, do this routinely, from my experience. Moving forward, so from after 10 years I got diagnosed. The following 10 years I kept working between 2011 and 2021, until I started reaching a point where I was so exhausted that I was like, okay, I cannot work anymore, I cannot travel anymore that much. And then it's finally when I got redirected by a neurologist saying, you'll probably need a transplant. And I was like, that's crazy, right? So somebody's going to rip the lungs out of me. Anyways, that was 4 years ago. I lost completely all my lung capacity in between. So a year ago, I wasn't walking. I couldn't get up off my bed. I was in a terrible condition. And finally, in February, I got the lung transplant. So it's been now just 7 months. I woke up from the lung transplant, again, not being conscious of this battery analogy, but suddenly I was like fully charged. It's only then that I realized how bad it was. When I suddenly woke up and started, wow, and the symptoms, my body wasn't working, my brain wasn't working. There was a moment I wasn't able to make a full phrase out of exhaustion, but also out of capacity to analyze, because your brain progressively shuts down as well to save the oxygen. Fundamentally, the body takes a while to heal, but the brain heals instantly. You just put back oxygen and suddenly your brain wakes up and everything, you know, becomes so crystal clear again. So that's really when I realized. And where I'm getting with this is that I think there's an enormous part of education also for patients, for self-diagnosis, for caregivers and so forth. It's an invisible disease. But then, you know, to talk about oxygen, of course, between 2021 and 2025, I had the privilege of receiving every type of oxygen that was available, concentrators, continuous flow, high flow, while I was progressively making my way on the path towards the transplant. And that kept me alive. So, you know, supplemental oxygen it's basically, I mean, I know you all know this, but it's a lifesaver for me, but for many others. And obviously, it's an easy lifesaver because the oxygen is just there in the air. And that's part of the problem and also part of the solution. The problem is everybody, when you talk them, I need more oxygen, they're like, well, it's there. Yeah, it's there, but not in the form I need it. It's in the air. The problem is my body is not concentrating the air into oxygen anymore, not filtering anymore. And that's where I need the help of this external machine. These machines are relatively expensive in this industry because they make extraordinary portable machines with lithium batteries, etc. But we saw in COVID that they're actually pretty simple to build, do it yourself. So there's probably a path towards open sourcing and making machine cheaper, but you know, I mean, they're so essential in the sense of keeping people alive, or you know, even as a therapy for those who can be simply cured by having more oxygen. That I really encourage everyone who has the capacity, from you know, from the funding from government to those who develop the programs to the practitioners, to really keep pushing, keep using the patients who've been through it as a voice, because it's only afterwards that once you have the oxygen, that you understand the effect it has on you. For me, it was incredible. It gave me an extra lifespan and a second life. When I had the machine, suddenly I could go start moving again, doing some sports. The sports allowed to keep my body ready for receiving the lung transplant. I mean, it's basically been a total blessing. Why I'm
Alex,
out of
we're going to
time.
have to wrap up in a minute. We have 2 more speakers. I know you could talk for a long time.
Yeah. So fundamentally, I mean, I just wanted to share all the work everybody here is doing, how, you know, grateful the patients are, the difference. I've been in a privileged country, but I see, and I'm also trying to participate in my new life now. I'm investing in companies, I'm helping companies develop. So feel free to contact me if there's anything I can help with in terms of establishing contacts and so forth. But in general, please keep pushing. It's extremely important, and spread the message. Thank
Wonderful.
you.
Alex, thank you. And we've dropped you wrote this yourself. This is your story in your own words. We've published it today. And if you want to reach out to Alex, if you could drop your email in the chat, I'm sure people will reach out to you. We have two more speakers. This next one is a very quick update. So if you found out about this webinar because you saw that lovely picture of the young girl she's from Kenya on the little social media card, that's a real teenager now, Missy Kananu from Kenya. And we learned about her because of the good work of 2 journalists at the Daily Nation in Kenya who told her story. She's a little girl with, they're not sure what the diagnosis is. They suspect post-TB lung disease. There was no way to get oxygen to her home, which is a village. So she has to live in the hospital. She can't see her family. She can't go to school, although she's perfectly capable of going to school. So this is a little girl whose life has been utterly disrupted because oxygen could not be made available at home. We have one of the journalists with us, David. David, do you want to come on and just give us a quick update on Missy Kananu? Is she still living in the hospital? Because your article is over 12 months old now. What can you tell us?
Hello, hello, hello.
Hi, David. We can hear you. Go ahead.
Yes. Sorry, I'm on the road, but I hope you can hear me well.
Yes, go ahead.
Yeah, so the story of Missy, we came through it on in last year, and even after we told the story, she's still in hospital. When we did the story, the power provider or the Kenya Power and Lighting Company, it supplies electricity to the citizens, committed to supply power to their village, because the biggest problem for Missy is that she cannot live at home. She cannot be at home because the oxygen concentrator that she uses must be changed. And she comes from a very remote village where she cannot have access to electricity or solar, any form of power to charge a concentrator. So she has been living in hospital. Even to date, she's in hospital. I followed up with with the the power company, but they said they are still working on the project of supplying the village. Of course, they also look at the numbers because that village is very remote. It's in a remote part of Meru County in Kenya. So they are still working on connecting her home so that she can go back home.
Okay.
Yes.
Okay. Thank you, David. I see the other journalist, Helen Shikanda, is also with us. Helen, did you want to add anything?
Thank you so much. I feel my colleague David has already said everything. And just thanking you for highlighting Missy's story, because she has been in hospital for, this is the third year now. She went there when she was 11. She's almost turning 15. And just been staying in hospital just because their village does not have electricity. And the only way she can survive is by being in hospital where there's oxygen provision. So we will also do a follow-up story a year later just to see any updates and to ensure that the Kenya Power and Lighting Company has done what they promised last year. Because when we wrote the story last year, they reacted almost immediately and they promised that they would go and put up power in their village, but that has not happened now. So we wanted to wait for about a year and then we do a follow-up story. And thank you everyone for listening to us. Thank you.
Thanks so much, Helen and David, and thank you to journalists like you who tell these stories. There must be many, many Missies out there in other parts of the world who are struggling in the same way. You can rest assured that because the story is public, we will make sure to share her story widely during the UN high-level meeting next week. So, and we hope that because of all this exposure, there'll be a solution for her and she can return home and return to school. But thanks very much for joining us and giving us an update.
Thank you so much. We will appreciate it.
You can also find Helen and David on X, and I've just shared the link to their article. It's a very, very compelling article that they published. Our final speaker today is Rosalind Turkey from the NCD Alliance. If you don't know the NCD Alliance's work, you should. Anybody working in any area of NCDs needs to really pay attention to this really powerhouse advocacy group. So this issue we've talked about today, medical oxygen and NCDs, is a small part of a much bigger agenda in terms of access to medicines for NCDs, which the Alliance is leading on. So Rosalind, over to you to zoom us out and give us a sense of what we can expect next week at the high-level meeting. And then I'll take a few minutes at the end just to wrap us up. But over to you, Rosalind.
Thank you, Leith. And hi, everyone. And thank you for the wonderful presentations today. I'm going to try and wrap this up on time by, as Leith said, zooming out and giving a high-level overview of what's taking place next week, the 4th high-level meeting on NCDs, which takes place on the sidelines of the General Assembly, and how the Access to Medicines agenda fits into that. So the political declaration to be adopted next week is a very important milestone, especially as only 19 countries out of 192 are on track to meet the target of reducing premature mortality by NCDs by 1/3 by 2030. So this high-level meeting is a really important moment to center NCDs, including mental health and neurological conditions, in the global agenda and to inspire progress on the global burden of NCDs, which is unacceptable, inequitable, and increasing. So member states have renewed their commitments to many of the principles and actions which were set forth at the 3 previous high-level meetings in 2011, 2014, and 2018. And while there are still gaps and missed opportunities, one of the achievements is the inclusion of operational language on improving access to affordable NCD medicines, diagnostics, and health technologies. So governments will agree on 2 clear targets related to access to medicines by 2030. The first one is that 80% of primary healthcare facilities should have essential NCD medicines and basic technologies available at affordable prices. And the second target is that 60% of countries should have financial protection policies to reduce the cost of NCD services, medicines, and diagnostics. So this one's really important to ensure that the cost of services and care does not push people into financial hardship. This is a step forward from 2018 in terms of the access to medicines agenda, when discussions at that time were focused mainly on using TRIPS flexibilities. So this new declaration really looks more at operational solutions across the pharmaceutical value chain. It actually specifically mentions pricing policies, price transparency, strengthening regulatory systems and procurement, including through pooled procurement and resilient supply chains, and promoting local production, transfer of technology and know-how, and commitments to voluntary licensing. So these are really specific tools and policies that member states can apply to their national context. So it's very important that they're mentioned specifically in the declaration. And in this context, I would like to highlight the new report, which was commissioned by the NCD Alliance, which reinforces many of these same approaches. And the report was written by David Watkins, and it shows that access to medicines is arguably the largest bottleneck to expanding NCD services. And it's also the main driver of financial risk. So this creates a double-edged sword in many low and middle-income countries, where low access to NCD medicines is combined with high out-of-pocket costs. So that's why that target on financial protection is so important. And David Watkins also has found that access issues are due in part to 2 key issues. First, governments appear to be underspending on NCDs relative to the estimated resources needed to meet population needs for essential services. And then secondly, the current resources are being used inefficiently. So for example, some stable chronic conditions are often being managed at hospitals instead of primary healthcare clinics. And then the cost of medicines also varies widely. So this suggests that many countries are paying too much for these medicines. The report also finds that if medicines were procured at the lowest observed prices, then spending needs could be reduced by 20 to 50%, which is huge when you think about it. So this really underscores the real impact that smarter policies and coordinated action can have on access to essential medicines and technologies. So for the NCD Alliance, the declaration provides a strong platform to push forward, though important gaps remain. As we've heard today, medical oxygen continues to receive little attention in global NCD policy discussions, even though it's a life-saving therapy for many chronic respiratory conditions, and a very critical part of comprehensive NCD care that needs to be addressed as countries move from commitments to implementation. It's also important that WHO guidance recognizes the importance of medical oxygen for NCDs. And there were also missed opportunities in the political declaration to make more progressive commitments to tackle NCDs and their risk factors, which is particularly significant given the high costs of meeting the oxygen needs of people living with COPD and other diseases. And the Lancet Commission has recommended a strong focus on reducing the demand for long-term oxygen therapy through reducing risk factors, such as curbing smoking, limiting exposure to outdoor and indoor air pollution, improving diets, etc. But however, the political declaration showed a lack of ambition on fiscal policies, such as implementing strong health taxes and health promoting subsidy reforms. It also rolled back on commitments on creating health promoting environments, and any mentions of proven or cost-effective prevention policies were weakened or removed. So from a prevention point of view, without any meaningful action to address the commercial determinants of health and to manage conflicts of interest, then countries will not be able to take the comprehensive and multi-sectoral approaches needed to reduce the NCD burden. And I'm just going to conclude by saying that this is a time when we shouldn't underestimate the power of strong, coordinated advocacy in driving change. This is what NCDA is trying to do through our Global NCD Access Advocacy Plan, where we're trying to bring together civil society organizations across different disease areas to build momentum and to tackle access barriers collectively. So yeah, to conclude, national action is critical, and we should not forget that the political declaration is the floor and not the ceiling. Countries now have to deliver with stronger prevention, financing, and also accountability to accelerate progress on the Sustainable Development Goals. And beyond global targets, this is about saving lives and protecting communities and also building healthier and more equitable futures for all. So I will put the links to our policy brief on the political declaration and also the report that I mentioned in the chat. And thank you very much. And I think I'm just about on time.
You're perfect. Thanks, Rosalind. Yes, drop those in the chat. Okay, just to wrap up, I think I can do it in a minute. I want to thank our fabulous speakers. Very compelling. We took a good approach to this issue, but I don't think we've covered all angles. We have our work cut out for us. It's just beginning, trying to get medical oxygen into the access to NCD medicines agenda. We want to make a little bit of progress. We probably won't achieve everything at this UN meeting. What I can give you is just out this new statement in the link in the chat. The Lancet Global Health Oxygen Commission has just released a statement, their first, on medical oxygen and NCDs. Please click that link and help us share it on all the social media that you normally use, on your email networks. We can use this statement to try and wake some of our government leaders up who'll be coming to the UN next week. So please share that with all the individuals, the missions, the ministries of health, the contacts you have in the governments, because it's the governments who will actually decide the outcome of the political declaration. Expect more from us on this issue. We're very conscious as well at Every Breath Counts that we haven't covered NCDs as effectively as we should have in the past. So I look forward to deepening our engagement in that with you, in partnership with you, in the months and years ahead. Thank you so much. And all those attending the UN next week, we wish you a very successful, productive meeting. Thanks all. All these, oh wow, those hands exploded. Thanks everyone. Have a great week. Good to see all these familiar names. Thank you all.